Today I have the distinct pleasure of introducing Chief Resident Dr. Radhika Rastogi. Radhika was raised in Metro Detroit, Michigan, and graduated summa cum laude in biomedical engineering from Wayne State University. She then earned her Doctor of Medicine degree with high distinction from Wayne State University School of Medicine in Detroit. Throughout her residency, she has advocated for residency improvement in education throughout various roles in the program, including the Program Evaluation Committee, Residency Council, and as the Moonlighting Coordinator, during which time she advocated and initiated for an equitable increase in resident moonlighting compensation. During her time in research, she investigated therapies to delay pathologic damage in critical care conditions such as myocardial infarction, sepsis, and hemorrhagic shock under the guidance of Dr. Zikon Yang, and has publications in several peer-reviewed journals. She has additionally won research awards for her work, which include creating a forcing model of abdominal sepsis and demonstrating the efficacy of topical neck cooling in delaying the progression of sepsis. She will be pursuing a fellowship in abdominal transplant surgery at Mayo Clinic in Arizona following the completion of her residency training. Outside of medicine, she is an avid enjoyer of music, novels, hockey, particularly the Detroit Red Wings, and writing poetry. Please join me in welcoming Dr. Radhika Rastogi, who will be presenting her Chief Grand Rounds titled "The Pen May Be Sharper Than a Scalpel, an introspective look at poetry and surgery."
Thank you all so much. I really appreciate your time. And I wanted to talk about something a little bit different in terms of a hobby that I personally find pretty dear to my heart. And so I wanted to explore the role of writing, and more specifically the role of poetry, both in medicine and in surgery, and how it can be useful to us as surgeons. So some disclosures: I am an amateur poet. I do not have any degree or formal training in this, but it's something I love and I wanted to share. Part of this presentation is in the words of other people. And I'll be reading some pieces today, some of my own, and as well as much better ones by other people that I think are pretty meaningful. And just a fun fact, World Poetry Day was actually this past Saturday. So it's pretty fortuitous timing that we have here. So I wanted to start with some words by the first surgeon writer who's worked in proud me. This was Dr. Richard Selzer. From his book, Mortal Lessons, Notes on the Art of Surgery, from a chapter at the beginning called The Exact Location of the Soul. And it in part brings up, I think, the crux of the matter. Someone asked me why a surgeon would write. Why, when the shelves are already too full, they sag under the dead weight of books. To add a single adverb is to risk exceeding the strength of the boards. A surgeon should abstain. A surgeon whose fingers are more at home in the steamy bellies of the body than they are tapping the dry keys of a typewriter. A surgeon who feels the slow slide of intestines against the back of his hand and is no more alarmed than were a family of snakes taking their comfort from such an indolent rubbing. A surgeon whose palms the human heart as though it was some captured bird. Why should he write? Is it vanity that urges him? There's glory enough in the knife. Is it for money? One can make too much money. No, it is to search for some meaning in the ritual of surgery, which is at once murderous, painful, healing, and full of love. For eons, there have been writers who are physicians, many whose names we may be familiar with and others who it may be surprising to learn about. This has been ongoing for centuries or even millennia, but a famous such example we can start with is John Locke, the philosopher and inspiration for our Declaration of Independence, as well as a physician of his times. Others, including more recent examples, include Sir Arthur Conan Doyle, our creator of Sherlock Holmes, that I'm sure most of us know. He was both a surgeon and physician by trade, had a private practice that was less successful than his authorship career. There's Anton Chekhov, a very famous Russian playwright that most of us might be more familiar with from his concept of Chekhov's gun. And also Richard Selzer, who I just read about, which is someone who wrote more about medicine itself and the art within that. Even more writers, including Michael Crichton, who is a doctor by degree, though he never practiced, the author of Jurassic Park. And even Khalid Hosseini, who you might remember as the author of The Kite Runner, and practiced medicine for 10 years before he was able to focus fully on his literary work. A lot of these physician writers wrote about topics that were not related to medicine, but there are others who have taken to writing about medicine itself and having that as the forefront of their authorship career. Some of those include Atul Gawande, which I think many of us are quite familiar with his work, as well as even Pulitzer Prize-winning author Siddharth Mukherjee, who wrote Cancer, the Emperor of All Maladies, which if you have not read is fantastic. But physician poets are also present, but more scarce. The most famous of these is actually John Keats. He was a physician and a surgeon, and completed all his training, but then had to make a decision in which he was going to pursue poetry, but still died at the age of 25 from TB. However, he left an indelible impact, I think, on the field. There's Oliver Wendell Holmes, who is a well-known physician who actually was the dean of the medical school of Harvard for quite some time, but a very notable poet, and wrote a very famous series called the Breakfast Table series that was more about human life. There's William Carlos Williams. This was a physician and pediatrician who treated his local community for 40 years and wrote a lot of poetry that focused on observation and understanding what you are seeing before you in the now. And was also a big advocate of modern American poetry, where rather than the formal structure that was seen of the previous times, focused on form rather than necessarily rhyme. And then Robert Bridges. He was also a surgeon and physician, and was the UK Poet Laureate for several years in the early 1900s. Many others exist, but these are among those who are the most acclaimed. And even amid those who didn't, right, there was a surgeon who's quite famous, who's also known for his enthusiasm for poetry itself, including DeBakey, who is someone who enjoyed poetry a lot, so much so that his colleagues and his patients would write him verse and share that with him. And he was a strong advocate for the humanities and medicine to create a more well-rounded physician and have that as a critical part of our training. So this brings us in part to the why. Why writing? Why poetry? How can that be helpful to us as a resource? And I'm going to come at this from a couple angles. One is more well-versed. Medicine is a special field. It's at its core where we are experiencing the distillation of the extremes of the human condition. There's the biggest joys where we have births, and the greatest tragedies and sorrows where we encounter deaths, or people going through some of the hardest times of their lives. What that means to them and how that is something that is a shared experience. And it's more intimate because of this patient-physician rapport that we have. We become entwined with their lives and are a huge part of the discussions that we carry with them and how we progress. So it allows for a unique union. Science as the secrets of the body, but patients, which reveal the secret of the soul. Surgery takes this a step farther. It provides a unique intersection where we provide direct intervention. Surgery is quite literally within our hands. That leads to a level of patient responsibility and accountability, as well as a very unique level of intimacy, secondary to the trust that we have been privileged to get. And it leads to a pretty incomparable experience that allows us to be part of their lives and undergo similar experiences, which both writing and poetry can uniquely express. But surgery, because of the responsibility that it holds, can be a double-edged 11 blade. So in some of the words by Emily Dickinson, surgeons must be very careful. When they take the knife, underneath their fine incisions stirs the culprit, life. So while it can provide the fulfillment that we see there, there's another side to surgery that we must contend with, and that's complications. We know this. We just talked about it in the previous hour. And it's easy to look at complications with the Clavin-Dindo score and determine what went wrong, establish OFIs, plan to be better. And of course, as the adage goes, if you do not have enough complications, it's because you have not operated long enough. So it's inevitable. It's part of time. But this has a second layer. Surgical training emphasizes confidence and accountability, decisiveness, precision, and perseverance. We aim to get things right but complications still occur at a 10% rate. This can have a pretty significant impact on surgeons, particularly more than just poor patient outcomes, but also an impact on surgeons themselves. And this is an underexplored part of the field. So first, there is the concept of a second victim syndrome, where the adverse impact that is led by feeling responsible for adverse events. And this can be quantified in a variety of stages. Probably a lot of us have been through this. And most of these stages occur, not necessarily in their full extent. First is the chaos of the adverse event. Something happens, we have to react to it to be able to handle and create the best outcome that we can in the situation that we have. Once that occurs, however, is the subsequent cascade. Intrusive thoughts are a critical part of this. What should I have done? These can linger for days, to weeks, to months, and years. And as part of learning how to handle that, there is a fear for rejection or seeking confirmation, where people handle these intrusive thoughts in one of two ways. What will my colleagues think? Seeking confirmation, talking to seniors that they feel that they can get advice from, or fear of rejection, where you might hide because you fear that because of what happened, things don't go well. The unfortunate part of this that often occurs is during the inquisition. A critical part about adverse events is trying to figure out a way that we can prevent this from happening again. Part of these are events like M&M or root systems analysis. They're very important. But another part is that they can have a pretty significant emotional impact, and that can include inquisition and analysis of the events that can be re-traumatizing. Part of the processing is also emotional first aid. A really important part of this is through seeking out support in your support system in terms of colleagues that you have and other people that allow you to understand and process what's been going on. And then the final disposition, and this can vary. Dropout, where this is too much and it leads to changes in career pathways. Or you survive and you get through it, you understand what's happening, or you can thrive and make meaningful changes that allow you to continue forth in your career. This can also manifest both physically and mentally. This part of this is a sustained adrenaline-induced response. That something can last 2 days or months, and it can lead to exhaustion, difficulty in focusing, insomnia, and difficulty in performance. Added concerns include fear of litigation, as well as guilt and self-doubt, and potentially decision paralysis, which can be both in clinic and in the operating room. Some folks turn to substance use. There's a 10% increase in substance use in folks who experience, particularly surgeons who experience an adverse event. So it is a high-risk system. And among other things, support systems in discussion have been a known and one of the best ways to understand it and process these events. But up to 25% people don't seek out people to talk to. Barriers in seeking out support are familiar. Lack of time. None of us have time. Uncertainty or difficulty to access. Who do I talk to? As well as concerns about lack of confidentiality. What is the impact this will have on me, on my career, on my reputation, and where will I go next? As well as the stigma. Complications manifest in changing practice. This is often familiar. This can be very beneficial. We're not ever doing that one again. We all know that. But it can be limiting when you suddenly cut off options that you had before. And this is a quote that's long stood with me. I first heard it at a conference by René Lariche, a French surgeon. Every surgeon carries within himself a graveyard where from time to time he goes to pray. It's a unique and quite frankly difficult thing to contend with. And even in my stages of my career, I can attest to this. And sometimes to help process these events, it's good to have an outlet. I have a close friend of mine who is an ophthalmologist who had such an adverse event and wrote a poem that I would like to share. I will be reading some poems throughout this. So this one is called Abogado. I am not worried. I have a good lawyer. The interpreter glanced over at me, discomfort visible in her expression. as all year in that small, dark exam room suddenly stopped working. El Niño Jesus. The woman beside me laughed, relieved. Oh, that word, it means advocate. It also means advocate. And I, professional in training, tried to mimic her reassuring smile. As I returned to explaining my plan to arrange for someone else to fix my mistake. I struggled to look into my patient in the eye that I had enabled. Later in bed, under the wooden cross my father had proudly nailed to my wall, I lay haunted by legions of pious grandmothers, by my own pious grandmother, kneeling before the creche of the infant Jesus, therein containing all love, patience, trust, vulnerability. In thought of the two, I'd rather face the courts instead. So it can be hard. And I think all of us know this. But my friend said this allowed her to process a lot of the feelings that I think were very difficult. Another part of complications is grief, both for the patient as well as a sense of self, which is so often tied to our abilities. It leads to a phenomenon known as disenfranchised grief. Grief that individuals experience when they incur a loss that is not or cannot be openly acknowledged, socially sanctioned, or publicly mourned, which can also have more lingering impact as it's more difficult to process and have support for. On the topic of grief, I would also like to add that grief outside the work is a difficult thing to process when you are often so forced to be in it, particularly in a space of residency where time is more limited. I experienced the loss of my brother 3 years ago, which I still have difficulty working with, and have used poetry as a source of expression and solace and remembrance in this space. But in either cases, grief is not something to erase, but to grow around. To have the capabilities to allow for this growth is difficult in a process that has many facets, and often a process that includes time. And this, of course, is something that we're in, but here's something that most of us are quite familiar with, unfortunately. Grief is burnout. Burnout does have an ICD code. Fun fact. It's a psychological syndrome characterized by emotional exhaustion, depersonalization, and a reduced sense of personal accomplishment, and it results from chronic workplace stress. It's seen in up to 47% of physicians, and in residents up to 74%. It can increase with PGY year, definitely increases with intern year, and it's worsened by lack of sleep and complications. And you can see symptoms such as anxiety and fatigue, insomnia, which is a vicious cycle, disengagement, difficulty in focusing, depression, and decline in physical health. Burnout is not benign. And it is multifactorial. It's highlighted by the training and residency, but it doesn't go away. Some of this can be the lack of work-life integration or work-work integration as some of our lives. It can be the moral distress, sometimes in the decisions you make, sometimes in the decisions you witness other people make, and that you have to contend with as a resident. Sometimes it can be depression and mental health, which is something that I think is important for all of us, or a lack of well-being. You're ill. So many of us come to work ill. That's very common. Or a lack of community. This is a critical part in support systems, is having a community that knows you. And part of that is also, if you're a marginalized physician, that the aspects of diversity and inclusion become important. People who have your lived experiences and provide your lived support. Also, the attrition of the surgical workforce. Less people, more work to go around. So burnout is something very important. In the prevalence of this topic, my own experiences did lead me to write a poem on burnout that I will share. The burnout. We treat the sick. They come to us failing, organs and minds and systems ailing, trying to get well quick. We ease the sick as they pass on to unknown lands or heal enough to grip onto life in their loved ones' hands. And yet we are the sick. We donate our blood, sweat, and tears, and work and work and work, sacrificing our sleep, mind, and fears. The sick are treating the sick. Death mars the patient and sticks to the soul of a physician like an infection, a contagion. Malaise spreading with touch. As it is removed from one, it enters the other. Even as the patient recovers, it is the doctor that it slowly smothers. So who is healed in the end? When the sickness is simply passed on, the body may be strong, but the mind's filled with doubt. Now, how can this illness be burned out? Part of this question leads to its most extreme manifestation, and that is suicide. Long work hours, the burden of frequently making life or death decisions on the part of surgeons, often by the minute in the operating room. Burdensome changes to the healthcare system, and the system that doesn't allow us to practice medicine to the full extent that we would like. A lack of autonomy, more time stuck, spending time on the computers, all have led to increased risk of suicidal ideation and a risk of dying by suicide. Among physicians and residents, there's at least 10% population that has suicidal ideation. This is not normal. This is much higher than the average risk. And there's a higher risk of dying by suicide in physicians. Earlier studies in the early 2000s estimated that there were maybe 300 physician deaths by suicide a year. Surgeons are amid the highest risk of violent deaths reported to the CDC between 2003 and 2017, which were around 700, much less than the projected number. 71 were surgeons, in part because of the extent of what we do and the extremes of what we do. So surgeons with lawsuits due to adverse outcomes in the prior 2 years are 1.6 times more likely to consider suicide in the subsequent year. In addition, those who consider suicide are 3.4 times more likely to report a self-perceived medical error in the prior 3 months. We have a big impact and a big tie in our identity in how we do and how we perform. And there's a lot of limitations in, again, getting treatment. There's a culture of silence, a lot of stigma associated with this, a focus on stoicism. We can get it done. We're strong enough for that. And of course, time. Who has that? No one. Just a plug, 988 is the national hotline, national suicide hotline, if anyone ever feels the need or knows someone who feels the need. But this suicide of Dr. Lorena Breen during COVID, which unfortunately we at UVA are intimately familiar with, has brought this topic to the forefront. And in 2023, at the American Surgical Congress, there was an excellent, rather profound presidential address that was given by Dr. Carrie Cunningham, who is the president of AAS, called Removing the Mask, where she told her story of depression and sorrow and complications and struggles. So if this is something that you want to look into more, it is available on YouTube. I highly encourage you to watch it. This was something that I saw, and I was a part of that the week I found out my brother had passed. So it was very, very meaningful to me. But it's something that I encourage others to look into. So this brings us back to the why. I was talking about poetry. We've been talking about very heavy topics. Why are we here? Why writing and why poetry? Among numerous other benefits, it can have a therapeutic impact. There is a lot of research done on expressive writing. This can be a trauma response technique. There have been studies that have shown that writing about events that are traumatic and expressive, and folks that find this helpful, now this isn't 100% of people, but most people, there is no negative impact or increasing anxiety in the time of writing, but 3 months down the road, the amount of anxiety that you have decreases. Similarly, an error-related negativity, which is concern of from errors and the errors that result from this, in folks who have a chronic level of worry, which I think is quite a lot of us, the use of expressive writing has shown to decrease this and also allow the mental workspace or how much working room and thinking room that you have to be increased. So you are more capable and more able to write when you use expressive writing. Now, this isn't anything specific. It's putting your pencil down to paper and writing about what happened and how you feel about it, which is not always, the most glorious thing to think about, but it is very helpful. It can help people deal with difficult emotions. That helps with coping and brings coherence in a lot of these very disruptive events. It also has shown to reduce PTSD and improve mood overall. Experimental disclosure, this is writing or talking, but the idea of discussing all of these has been helpful as a critical support tool. And then there's increases in the benefit of narrative medicine itself, where we look at medicine through writing. And that broadens how we are able to interpret our experiences, both from a medical standpoint as well as a humane standpoint, and both for our patients and also ourselves. Poetry therapy is a more specific delineation of this. It can act in a way as a type of art therapy. It allows for both a medium to express emotions in patients. This has been seen in many fields. This has been studied most actually in psychiatry, which is not surprising, in addiction medicine, but in somatic spaces, in somatic medicine, if you were. There has been studies that have shown, interestingly, an improvement in your immune system with an increasing CD4 count in an HIV population with poetry, as well as improvement in the cardiac response. With poetry just recited in hexameter, there was a synchronization of the cardiovascular and respiratory response noted in people at rest. It was a pretty limited study, but nevertheless, these do show that there is a somatic response to all of this. And then a more relevant, or not more relevant, but more studied space that this is also seen in is in palliative care as well as oncology. These are people who have a very difficult time and very sensitive time in their lives, and it allows patients to understand and process their condition and their future in the context of what their life is. It also allows them to have a sense of empowerment, because these conditions are often things that are very destabilizing from a sense of self, and it helps reestablish a lot of that. In a way, for physicians, this also has similar potential. We are also in some ways patients and second victims in a lot of these experiences, but it can allow us to both better bond with our patients if we would like to do it in concert or share work later. But it can also be something more private that allows folks to be able to process everything going on. And this has been integrated in a pretty limited sense into the medical sphere. So there's been an interesting medical humanities curriculums that are seen in medical schools. This is something that people are trying to focus on, to be more holistic doctors, to be able to prevent disenfranchisement. But one of the risks with this is where is the time? In medical school is one of those places where we still have structure and time that you can allot for people to have the resources to gain the tool sets they need for their future. There has been in Stanford a study that was pretty limited, but in an inpatient curriculum, integrating narrative medicine once a month in one of their busiest rotations on internal medicine, which was medical oncology. Everyone came in burnt out. Everyone apparently left that rotation more burnt out for scores, but there was a reduction in this increase in burnout with this narrative medicine. Where's the time? They used to select dedicated education time in which they would have these courses, and they would have someone who was trained in narrative medicine work with the residents at that time. And some of the benefits actually included also increased bonding within the team, because they're able to process these shared experiences together. That can sometimes be harrowing. There's a famous Portuguese surgeon and poet, Dr. Barreto Guimarães, who's a breast surgeon, and he has also established fundamentals of modern poetry as an elective at the University of Porto in their medical school, where students can take a break from the, fire hose that all the medical knowledge is, and take an idea of how you can understand the structure of poetry and understand how that can be helpful. I think both to better understand the patient, but in my opinion, it's also a big part in better understanding the doctor. There's also been an increase in medical poetry as a published medium. Increasing amount of medical journals are having a humanities section. We see this in JAMA Oncology, the Annals of Internal Medicine, the Journal of Humanities. UVA itself has a journal of medical humanities called Veritas, and then others, including Ars Medica, Intima, and many more. The editor of this, Dr. Rafael Campo for JAMA, has mentioned that he receives over 200 submissions a month to JAMA itself. So this is something that is prevalent and is something that people use a lot. And he has also noted that most of the authors who submit say this is among their most read publication. And it's something I think that can connect to us, that even if we are not capable of writing or don't necessarily feel the need, reading can leave a big impact. And this also leads to shared perspectives and decreases isolation in a space that can be hard. There are a couple poems that I would like to read to you that I've heard from this. The first is from the Annals of Internal Medicine in 2013 by Dr. Bonnie Salman. DLROW. Here comes that intern with the wispy mustache. Poor thing. He never knows the date, the day. Always keeps asking me and has to write it down. He says I remind him of his grandmother. Sweet. But I don't know her, so why does he say that? He can't spell either. Asked me to spell world backwards. Waste of time. I know it's backwards. Don't you see? To end up here in a wet diaper, a baby, with a bid among cooling nurses? Should I tell him my secret, this boy who can't spell? I have two hearts. When the surgeon takes one out, they'll find the other one still strong, still beating. I read this in medical school. It's reframed every interaction I've ever had with someone who is delirious or demented. And who I ask these questions. I asked them this morning. One of my patients had a bird cough. And it's something that lingers in a very specific way. To understand that these are people in your trust, but these are not who they are, always are. And also what you come up as in these interactions. And this is another poem. It's closer to our surgical experiences about a pediatric trauma by Dr. Camilla Glenn Rogan. It wasn't her face. It wasn't her age or the story or the blood. It wasn't even the hole from the bullet where it had blown off her ear. It was the nurse tucking her in, smoothing her blankets, arranging her hair. It was the sound of her mother's sharp wail as we walked away, as she collapsed on the floor. I think we have all been in pretty traumatic situations. In allowing for the humanization of the family and the patient, when this is more than a story and more than a hole on the side of her head, is important. When I was a medical student, I still remember a patient dying and their family wailing on the floor for 20 minutes. And it's heart-wrenching, and it's something we see, but it's not something we can internalize all the time because then we can't go forward with our job. The balance is present, but this helps process it. So poetry. It has a lot of things. It leads to observation. This is a critical part of our job. We observe to diagnose. We observe people to understand their story. We have a preclinical patient discussion. Are they frail? What is their life like? Is it worth it? Or are they with their family? What do they do outside of work? How do they enjoy their life? Can I help them keep enjoying their life? This observation lets us be a part of their lives, but it also helps us in terms of processing everything that's going on. And it allows for an element of humanity and empathy, building relationships with patients rather than just being like, this is someone who has a tumor, I'm going to cut out the tumor. Or as the more famed quote, there's a fracture. But understanding the patient is really important. What poetry also allows is to reframe a perspective. Sometimes we are too close. In poetry, sitting down and writing allows us to have some distance to better understand, both in terms of what this is to me, what this is to you, and what this is in the context of the world. It can be very helpful. And one thing I surprisingly found very helpful in poetry is structure. Poetry has a wide variety. It can be formless. It can be something that I recite in words, but it has to have some level of structure. Sometimes that can be a rhyme scheme. Sometimes it can be the framing of the way the word is written. Sometimes it can just even be the cadence of the sound. But trying to write intentionally to make a form of structure makes you think more about it. And that has been something that has helped me think more about it, and therefore leave a more emotional frame of mind to a more thinking frame of mind and be able to process better. So it allows for remembrance. This is something that I found pretty important. In 2023 and 2024, I probably wrote the most poems I've written in the last 15 years, and about half of them were about my brother. I don't ever want to forget anything. And so you are able to remember when you write things down, and you are able to remember forever. And for a lot of patients, that can be remembrance of their lives. For a lot of physicians, it can be remembrance of our relationships and what's been happening, and to allow that to be processed. So I did want to finish with a couple poems that I have written. This one is a bit more joyful. Spiritual joy. And I know I have shared it with some of you here. And it is called I Have Eviscerated a Man. I have eviscerated a man, mouths spilling over the confines of their home, my hands elbow deep with blood that ran in red rivulets over my arms onto the floor. I have eviscerated a man, but not to kill or steal a life, but to staunch the flow of blood, to use a knife and cut out the hole in the lengths of bow and remake the body whole. I have eviscerated a man, not just because I can, but it's not the first time. But I swear it's not a crime, a passion, but I do it with zeal, if only to find me seal, shut the leaking vessel and guts, more a sculptor with careful cuts of the chisel to carve away what is injured, not to slay. And yet still I can say, I have eviscerated a man. And I have one more poem that I wrote that I want to share with you all to say thank you. The Voices of Giants. They say you hear the voices of those who trained you, as your surgical choices unfold each day anew. A chance to cut is a chance to cure. Oh, the surgeon's allure. Or flow is smooth, and smooth is fast. An adage that's held steadfast. And as we frantically throw protein to seize the rush of red, while bleeding stops eventually, does run through my head. What more comes to mind, the voices of each one of you here, like an actor's lines to guide me as I enter the theater. Let's go through the colors of the rainbow, shall we? Let's start at the neck. Red. An accurate thyroid dissection earns a great, grand, wonderful. And if everything passes inspection, love it, brings it full circle. And we go to the stomach, orange. As I dissect during a hernia or sleeve, sometimes it's good to go slow. But other times, what I actually hear is go, 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 go. And with an errant move I make, I hear, no, 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 it's okay. Erase. And I continue forth relentlessly, because in the end, it will be fine. It has to be. So eat when you can, sleep when you can, and don't mess with the pancreas. Green. With the echoing call for symmetry, I carefully remove what's untoward, discarding any redundancy, which in other words, it's for the birds. And when we get in the figurative mud, blue. Divesting cancer from the colon, divert or not to divert, that is the question. Find the ureter and you're free. Or otherwise, I might hear, damn it, Charlie. In the midst of an emergent case, sometimes with a raised brow, you can never know what you face. Sometimes you can't make chicken salad out of chicken shit. Salad handled well and the patient leaving fit? Oh yeah, that's it. So every day, as Dr. Ruff may say, I'm living the dream. As I listen to the voices of giants before me and continue on my journey upstream. So I wanted to thank each and every one of you who has been so formative in all of my training and has helped me become a better person and a better surgeon. So thank you. And thank you all to the residents who I think are the core of what we are here and have allowed me to enjoy all 7 years. So I'm happy to take any questions.
First of all, everybody has grit and determination in this. But if I had to kind of pick one person that I can kind of think about in terms of all of this, it's been you. And for a lot of the things that you're so open about it, you talk about it, and yet you bring your best self every single day. And I'm grateful for that. You've been the final slide on my recruitment talk for, I don't know, 7 years. I guess I'm going to finally have to replace you, but I might not. And a couple things. Kyla Tahara now is asking for us to submit to the college to grand rounds that we've seen that we want to give on a national stage, and asking us, and I've already submitted some, but honestly, it's the chief resident talks and that are the best. I've already submitted 2 of them to her, and I might submit a third because that's spectacular. And I wonder if do you know that the Virginia chapter, there's the art of surgery. Have you ever submitted to that?
So interestingly, they have not published something in about 3 or 4
Well,
years.
I just said something to Susan. Are we still doing that?
I have reached out to them, but then it kind of went into a
I've not seen it
black
in
hole.
a while. And then but I think, why do you think that these things touch us all? I mean, I can't imagine not one person here wasn't moved. And it really gets at the heart of why we're surgeons, why we're doctors, why we did this stuff. And yet, sometimes when we try to put these into the curriculum, and we've had chief residents that tried to do that, we get met with such resistance. Like, why are we talking about this? Why are we doing this? Like, what's the point? And yet, it feels like every single one of us, when someone does a talk like this, are touched to the soul. So how can we figure out that discrepancy or that kind of conflict that we see?
I think I know definitely what you're talking about, and I think it's an important thing. But I think part of the struggle is we are in a career that is so asking for so much of our time. And so when we're like, we are going to use some of your time and do something that seems like fluff, the requirement of it, I think, is what's difficult. I agree that it's something that's important to do. And I think one of the best things is having that integration earlier so people know what resources they have or what tools they can have in their kit. So I really like the integration more in the medical school aspect, because then people know that, hey, you can try to do this when things suck. I personally have talked to Dr. Yost a lot, and part of what I did was actually write about every day for a month or 3 months after everything happened with my brother, but writing allowed processing. And I think having someone to just say, this is a resource for you, this is something you can do, and having those concepts is more beneficial than saying, here, sit down, we're going to require you to do this in a time that is not necessarily something we have. So people have to feel like they're going to get the benefit for them to fully engage. And having that buy-in is a thing that's critical. So saying, hey, this is hard. Would you guys want to do it? And have people who volunteer, and then people who maybe then spread the word that this is something that has been critical and helpful. Or have people also say, this version of this is not for me, but other people who might find this version of it helpful to them can have that process. So I think that's kind of where I would go about it.
There is something for faculty in particular, and the medical students probably know this, but the medical school offers a course every year called the Healer's Heart. I think they still do it. And I did it twice, I think. It's super time consuming. But surgeons are not typically involved in this. And we do need more surgeons involved in this. I finally did give it up because it was they asked for a lot of time for you. But if you're interested in this stuff, I'm happy to connect you with people, because it's a time commitment, but it's a good course to participate in.
Thank you.
Radhika.
Dr. Singh.
I just wanted to thank you for sharing yourself so openly and inspiring everyone. You know, it's usually in these conferences, any conference, a lot of people on their phones, and as you were reading at the end, nobody connected with a lot of people.
I wanted to thank you for our discussions that we have had about the poetry that we shared, and it has been a very wonderful part of the time.
This is a great talk, and, you know, wisdom. You found a very healthy way of dealing with your emotions. And I think that something that you talk about is support from, you know, your colleagues, support from other avenues. And I encourage all of you to take what she said to heart, to be kind to each other and show each other sympathy, because there's dealing with what we will all deal with as surgeons. You know, when you face difficulty, you know, within the profession, which everybody in this room will face over and over and over again, unfortunately. And sometimes we victimize each other and build a very unhealthy culture. So it's on you to build a healthier culture within your relationships with leaders.
I personally feel like our residency is fantastic at doing that, and I feel like part of my ability to be able to share this is how wonderful our residents have been to each other and supporting even from our attendings in this manner. So I wanted to say that specifically. Thank you all so much for your time.
I was just gonna say, they're my favorite talks.
I